Welcome to Life with Shenita. I am your guest host, Wendell Limitless Hollins. And on behalf of Shenita Connolly, I want to welcome all of you to this important show, which will be discussing a key topic, which is prostate cancer, and the impact that it has on men. I've got three great guests today, Dr. Charlie Bridges, MD urologist, Charlie James, a cancer survivor, and Bernard Shaw, who has a passionate love for men's health. So without further ado, I'm going to introduce our first guest, Dr. Charlie Bridges. Hello, Dr. Bridges.
Good evening.
Dr. Bridges is an MD urologist in Baton Rouge, Louisiana. He retired lieutenant colonel from the Army with 34 years practice in Baton Rouge and 4 years practice in the Army. That's just my brief introduction, Dr. Bridges. What would you like to add, sir?
A country boy from Mississippi.
All right. Sounds good to me. Our next guest, Charlie James. Hello, Charlie.
Oh, how are you doing?
I'm doing great. And this is another retired lieutenant colonel in another branch of the service, which was the Air Force. He is an educator with 13 years with the Morrow High School and a great individual, and like myself, a prostate cancer survivor. Charlie, what would you like to add, sir?
Also, another country boy from Alabama.
Wow, you have a lot in common.
Yes, indeed.
All right, well, I'm a city boy from Cleveland, Ohio, so don't hold that against me. Next, we'll have Bernard Shaw. Bernard?
Yes, hi, glad to be here. I guess I would be somewhat from the country, Wilmington, North Carolina, and around there. My father spent 21 years in the service, and I've been in the medical industry in the past in the OR as far as a spine specialist and medical device sales. So I've had two perspectives from the outside and the inside, and this type of discussion is absolutely necessary, and I hope those who are in attendance can also pass it on to others.
All right. Thank you, gentlemen. And I wanted to say again that this is a serious subject, but we will try to have an entertaining discussion while we cover all of these issues. But as an icebreaker, let's start with this question. When you die, what do you want to be remembered for? Who would like to go first?
I would like to be remembered as a good father, someone who tried to do his best and to, treat his fellow man the way he would want to be treated, always.
Excellent. Bernard?
I'd probably say I read extensively a lot, even at my old age now, and I take a great deal of passion in sharing what I learn with all types of groups, because if we share more knowledge, everybody benefits.
Excellent. And Charlie?
I want to be remembered for doing good things or helping people. One of my favorite songs is one of the song we used to sing in church, If I Can Help Somebody. And so I'd like to be remembered for the good things that I have done.
Excellent. Thank you. Kind of like me, one of the things, there's quite a few things I like to be remembered for, but one of my key things is that leaving a legacy for the next two generations of Black Americans. That's very critical and near and dear to my heart. So with that, let's get into the topic for today. And I'll start with Dr. Bridges. What is a prostate and how can men keep a healthy prostate?
Well, the prostate, contrary to most people's opinion, is for reproduction, not for sex. When I say reproduction, approximately 45% of the ejaculate comes from the prostate. And of course, ejaculate is, the secretions are important for reproduction. Now, to keep a healthy prostate, first you start out with keeping a healthy body. You want to keep your weight under control. You want to, if you got hypertension, diabetes, make sure you control these. You want to exercise. And of course, some of the things, or one of the things that may affect men's health or affect the prostate, I should say, is infections. So you want to be careful with your partners. You want to limit your sexual partners. That's just the truth. But for as anything specific in your diet, there's nothing that's there that's going to make the prostate healthy other than eating a healthy diet and trying to keep your whole body healthy.
Great. So my favorite smoothie, which is a strawberry chitlin and pig feet with yogurt smoothie, no effect on my prostate, correct?
Say that again.
The chitlin part.
Did you say a beet smoothie?
I said a strawberry,
Okay.
chitlin, pig
Oh,
feet, and yogurt smoothie has no effect on my prostate.
well, let's see. The chitlins are good for you. Pig feet, you got to leave alone. Strawberries, okay.
But Bernard, I know you are truly about men's health. Can you add to that, please, sir?
Wow, it's gonna be tough to top that chitlin and pig feet. And I used to eat them back in the day when I was young, didn't know what was going on. But Dr. Bridges said your overall health is a major factor in your body's ability to fight off any kind of disease or inflammation, as well as deal with cancer. So if you start with that, that's the first step. Because if you're not in good health, your body is inflamed. That's going to make it more difficult for your immune system to do what it needs to do to help you to weather that challenge. So focus on overall body health and reduce stress. It's really pretty basic. Start with that. And if something does come up, we'll have to rely on professionals like Dr. Bridges to help us work through that.
Excellent. And Charlie, what health tips do you have, sir? Charlie James.
One of the key health tips that I have is that for men to each year get that yearly checkup.
Yes.
Go to the doctor yearly if possible. I know that some men may not have the insurance to do it, but if you do have the insurance, make sure you go in every year to get that checkup so you can get ahead of anything that might be happening with your body. But also, while I have a full, like Dr. Bridges, to maybe give information about, we men hear a lot of things on TV about take this pill or take this or that. Are those things effective or not?
Actually, if they have any effect, it's more of a placebo effect. When you look at the clinical trials, all the formulations have been tried or compared to medicines that we use. They have shown only placebo effect at best. But to me, when people are taking herbs and mineral supplements, and that's basically what you're taking. And if you read what's in all of these different formulations, they all center around one or two ingredients of saw palmetto, some selenium, some other heavy metals. So they're basically all the same. You're taking a good supplement, a good vitamin. But if you're taking that, that tells me that you're interested in your health and you're interested in doing the right things to keep your body healthy. So I do not tell people to stay away from those.
Good guidance. Great guidance. And we all have to be mindful of our health, mindful of our history. For those of you who don't know, this is part 2 of prostate health. The first session that we did was on May 13, 2021. And one thing I admire personally about Dr. Bridges, he said that he would like to catch up with each one of us and how our health has been since that time. Since that time, as the first recording showed, I had prostate cancer in 2015. The first time I had cryosurgery, which they froze half my prostate. But I liked it so much, I got it again this year. So I had my prostate taken out this year, so I didn't want to do third time's a charm. Since that time, my PSA is not where the doctor wanted it to be, but it's close. So they're monitoring over 3 months. Then I'll go see my surgeon again, and I expect my numbers to be down within range, and that'll be the end of it. Charlie, would you like to provide an update?
All right. From the earlier show, I specified that I was diagnosed with prostate cancer on 19 October in 2019. They caught it early, and so there wasn't a big rush for me to do anything just right away. So I waited until the beginning of 2020, from January 2020 to March of 2020. I had 38 sessions of radiation treatment. And I finished the last radiation treatment on March the 9th. About 3 months later, I went in and had my PSA level checked. It was 0.70, which the doctor said was good, low. And then another 3 months later, I had another PSA, and it was 0.07, which was exactly where the urologist wanted it to be, or go in that direction. So I go back in about another 6 months to check out, and God willing, it'll still be low. And as they don't like to say with cancer that you are cured. Right now, doctor says I'm in remission.
I would like to point out the main thing that we're doing here is we're treating organ-confined disease, meaning that these gentlemen were undergoing, doing the annual follow-ups. They were found to have prostate cancer at an early stage that would allow them to undergo these treatments, cryosurgery, external beam radiation, even just radical prostatectomy that was follow-up with the host. We're treating organ-confined disease, and that's where we want to pick up this disease. We don't want you to come in with a PSA of 50 to 60, or the highest I've ever seen in my whole life was 6,000.
Wow.
That's not a good time. Okay, so it's important that we pick you up early when you have organ-confined disease. When we do that, the outcomes are, well, there's no comparison. Once it spreads, of course, there's no treatment to cure. It's only to slow it down and try to contain the disease. So the thing that these gentlemen had, the treatments that they've had, they got that because of organ-confined disease. And that's our goal as urologists.
Yeah, and thanks for that. And mine was to take through my annual physical, and correct me if I'm wrong, Dr. Bridges, but by the time, quote unquote, symptoms of prostate cancer shows, it's been in your body a very long time.
Except for maybe the obstructive symptoms of bladder outlet obstruction, where the prostate enlarges and slows the urinary flow, maybe giving you some frequency, some urgency of urination. Now, those symptoms are the same thing that you will have with benign disease. That's not a good sign. But if you come in with bone pain, weight loss, hematuria, you're right. It's late, very late. And you probably have generalized spread of the disease at that time. That's not where we want to find you.
Yeah.
Could you?
Does someone have something else you want to add?
I was going to say if the doctor could differentiate between BPH and what you said was involved prostate disease, because some people kind of get them confused. They think, oh, I just got BPH, and it might not just be that.
BPH is what we call benign prostatic enlargement. This is the most common disease of the prostate in men. It's a benign tumor that grows and usually starts about age 40 and tends to progress from there. It causes obstruction of the urinary flow. The most common early sign will be getting up at night to go to the bathroom. Stream becomes slow, complete emptying, starting, stopping. All of a sudden, your stream gets slow and you start spraying and you're wetting the flow, and the wife is hitting you upside the head, all this kind of stuff. I mean, that's BPH. But cancer can cause those same obstructive symptoms. So it's important to get that rectal exam. It's important to get that PSA indicating whether this is benign disease or this potentially cancer that's developing.
Thank you.
Yeah, and that's important to get it checked out to find out what's going on. Switching hats a little bit, but this is a topic that I know men are interested in as far as prostate cancer. And you touched on it earlier, Dr. Bridges. You said it's difference between reproductive and sex. A lot of men are cautious about having prostate, even discussing about their prostate, because they feel like their manhood is between their legs and they don't want to lose that. Can you elaborate on that, please?
You'd be surprised how many men think you're not going to mess with my prostate. That's my manhood. That's my sex life. And I look at them and say, well, if you're dying from prostate cancer, sex life is going anyways. So,
Good
so you have to look at it in a way that men can understand. One thing will happen though, as that prostate enlarges and blocks your urinary flow, eventually you're going to have to come see me, because either you're going to be in retention and have a catheter put in, or you're going to have so many problems and symptoms that you can't go out of the house because you're incontinent and wetting yourself. So eventually, as the gland continues to enlarge, you will seek some help, but that's usually late. We don't want you to get to that point. As I said, the prostate is for reproduction. Unfortunately, it does enlarge and cause obstructive symptoms to the urinary. You can have prostate surgery for benign disease or for cancer and still be sexually active.
Mm-hmm.
See, most men realize, oh, that's the end of my sex life. No, it's not.
Mm-hmm.
If you choose it to be that way, there are things that can be done and treatments that can be given to continue so that you continue to be sexually active. So having prostate disease, having it treated does not end your sex life.
Yes, and that's very true, and I can testify to that. Initially, you've got serious issues. I mean, with sex, and also even like you say, it's spraying all over the place, right? Or even making it to the bathroom one time. I mean, I had to wear the pins plus a pad into the pins plus pads everywhere I sat. But following the advice of a pelvic floor therapist and my surgeon, I don't have to wear pads anymore. So that's a good thing. For our sex life, there's so many things that can be used out there to help your sex life. Vacuum pumps, pills, Trimex. There's a lot of things that can be done, but go on the advice of your individual doctor as to what's best for you. But don't be hold back because of your lack of sex life. Because like Dr. Bridget said, if you're dead, your sex life is dead. So you have nothing to lose as far as sex, but to get it right. Yeah, we joked around on the first show about popsicle sticks and how that can help you hold up. But that's a joke. That's not medically proven. I'm not a doctor. Charlie?
Yeah, I just want is that one of the key things is communication.
Yes.
You must talk. And I mentioned in the first show is that there are some men who, even when they mention prostate cancer, they lower their voices as if they say the word out loud, something bad is going to happen. But we have to start talking about these kind of issues. You talk with the doctor, as we said earlier. My cancer was detected from a yearly exam. It was low originally, and then it started going up. And Dr. Bridges can add to this if I'm misspeaking, is that my urologist said if you do a PSA and it's above 5, then that's a sign that you need to maybe do a biopsy. Mine was 4, and then within maybe a 6-month period or so, it went up to 5. So then they did a biopsy. But again, that was because of having yearly checkups. So they got it early. But then I said, talk to your doctor. Then if you're married or in a relationship, you've got to talk to your spouse or your significant other.
Let me just briefly say that, we normally use a PSA range of 0 to 4 for everybody, but the older you get, the PSA tends to trend upward. So for your age group, probably 5 was the upper range of normal that your doctor felt was comfortable for you. I'm going to throw this out there, and this is very important because most men now think that you can do that blood test at PSA and you do not have to have the rectal exam. That is so untrue. Every year, I will find someone with a prostate nodule and the PSA is normal. So nobody wants to get the DRE that I know of. And it's uncomfortable. I have to get mine checked. Last time I was mad at my doctor, thought, so what did I do to you? So, but what I'm saying simply is this: you have to have both exams. You have to have the PSA value, and you have to have the rectal exam. Now, it's good to have that baseline PSA, okay? Just like Mr. Charlie says. So as every year he got his PSA, there was an increase.
Mm-hmm.
Increase, you start to realize, hi, something's changing here. And we not only use just the number, but the rate of change of that PSA value. In other words, if your PSA is running 1, 1, 1, 1, 1, all of a sudden it jumps up to 3, even though that's in that normal range, the rate of increase has been much too rapid. Makes me think, what's going on here? So that's when you become suspicious. So it's a combination. It's not just a number itself, but a change, rapid change, or that value. Excuse me. Another thing, just because your PSA is elevated does not mean you have prostate cancer. Okay. But it's an indicator that potentially there's something going on that needs evaluating. I have several men in my practice run PSAs basically 35 and 40. And of course, every time I see the numbers, I've been taking care of them for years. My eyes get big because, hey, this ain't right. But then you go through the data. They've had several biopsies. Some have even gone on to have resections of the prostate for benign disease, and there's no cancer. But when it becomes elevated, it's an indicator that you need to be evaluated promptly to see what the problem is.
Yeah, and I want to give an endorsement that, for everybody who hears this or make people aware that this is a very serious subject, and we've got experts on the call, especially Dr. Bridges, who will provide the real truth, and not what we used to call in the inner city of Cleveland, Ohio, barbershop law, where people are saying things of barbershop medicine, where they seem like but it's not true at all. Okay, and for those who don't know, layman's terms, a DRE, digital rectal exam, somebody sticks a finger up their butt and they probe, and that's what's uncomfortable. But again, do you want to be uncomfortable for a few minutes or do you want to die? Your choice. Bernard, what would you like to add, sir?
I agree. There's a lot that's being said out there. You're always hearing new articles about new treatments. And I can tell you from being in the medical device industry, you got a lot of money behind these new treatments, which sometimes it turns out they're not any better than what's been done traditionally. But they're heavily promoted. You get a lot of stuff in the press about them. So we have to really look after ourselves. I just want to share with you real quick. The Huffington Post, they put the major reasons why most men won't go to a doctor, such as too busy to go, fear of finding out bad news, discomfort of examination, prostate, rectal, etc., the doctor's, quote, personal, unquote, questions, and getting weighed. Think about that. Those are the reasons people don't go, and think about what's going to happen if you don't go. Dr. Bridget just talked about, if you catch it when it's in the organ, there are more options that can maintain having less of an impact on your overall health. But if you wait and wait and wait to the point it's spread, that becomes a whole different ball game, could be a life changer, and could have a really detrimental effect.
Yeah, and if you're worried about losing weight, one way to do permanent weight loss is to die. You will never gain weight. So if you don't have your prostate exam and you get that cancer, you got permanent weight loss.
Okay.
Yeah. I would say go ahead and preach, but
but
when we talk, we're kidding, but it's all because we're serious about what we're trying to get out here today.
Absolutely.
Because I see far too many men showing up with too much advanced disease of their prostate cancers, and that's not healthy. That's not good, because we know that the more advanced the disease, first of all, your outcome is poor. We can contain it a few years, but we can never cure you. So you're going to be living fighting advanced prostate cancer, and trust me, it's costly. It leaves you in a state of feeling fatigued all the time, and even though your numbers may look great, but just the medications and things that you have to take to control this, you're not going to lead another healthy life. You'll be active, you can do things, but you're not going to be the same. So the key here, the emphasis, if we can get that out, is early detection is where you need to be. Now, we can't prevent you from developing prostate cancer, but if you develop it, then of course, we want to catch it when it's still in the prostate. If there's a family history of prostate cancer, you're at high risk. If your father, your uncle, your grandfather, also if there's a family history of breast cancer, you're at high risk. So if we need to talk to our family members, our first cousins, our brothers, nephews, about disease process who has the disease. When I grew up, this is probably true in all the African American communities, old folks get to talk about people's health. You had to leave the room, boy. You had to go.
Yes.
That's the way it was.
Mhm.
They did not share the family history with, and that's to the detriment of us now. Okay, so it's important that we become ambassadors to spread the word, to let people know that, hey, early detection means a world of difference. You know, you go from being cured potentially to fighting metastatic disease until you die.
Yeah.
Simple as that.
Yeah, and that's key. Early detection is key, and part of early detection, like you said, all of us have said, is that whole piece about communication. I mean, there should not be a stigma associated with prostate cancer. But historically, at least when I was growing up, like Dr. Bridges said, you had to leave the room, or that was just family business and nobody really talked about it. It kind of fell in line with the whole discussion about mental health. No one wanted to talk about that. But we need to talk about it. We need to lay these issues out. And that's the importance of having shows like this, like with Shenita, that we can discuss these issues openly and honestly so that we all can move forward. One thing that I want to cover is after your treatment, be it radiation, be it some type of surgery or whatever, there are going to be complications from surgery. We touched on this a little bit, but I want to dig a little bit deeper just so men who are considering prostate cancer kind of level setting at a high level their expectations after their type of treatment. Who would like to go first to discuss that?
I'll chime in on that because we've already mentioned is that some of the symptoms that you have, even if you don't have prostate cancer, as you get older, you're going to have frequent getting up at night, going to the bathroom. And in fact, before I was diagnosed with prostate cancer, I had what was called the enlarged prostate, and it had gotten so bad as I was getting up sometimes 5-6 times at night in order to use the bathroom. And so as a result of that, and even in the daytime, is that if I was going on a long trip or going to be out for a while, we've already mentioned you may have to wear Depend. And I'm not sure, again, why there's a stigma of what having to do that. And you don't see it that much on TV anymore. They had started making commercials where groups of people or things were talking about that. And as I say, you don't see that much anymore. But I think they should keep doing things like that. It's time, as Wendell said, it's time to stop putting stigma on things that are associated with certain illnesses and disease. It just should become natural. And so having to wear Depend, especially on long trips or if you were going to be out for a while, that keep you from having to run to the bathroom. That's something that does go along with it. But as we keep saying, what is the alternative if you don't do these things?
Very
and
true.
that in mind is, yes, I might be in a little discomfort right now, but if I don't do these things or if I don't get checked, then what's going to happen to me?
And
Agreed.
if I could interject, like Dr. Bridges, to get into this, some of the treatment options in relation to robotic surgery and the nerve-sparing techniques that can be utilized for those men who automatically think if you have a prostatectomy, that's going to be the end of your sex life. Can you kind of get into those options?
Okay, we're dealing with organ confined disease. So when you start talking about doing surgeries, which we call a radical prostatectomy, there are different ways to do it. There's the peritoneal radical prostatectomy, there's the open prostatectomy, and the most advanced procedure right now is the robotic radical prostatectomy. Okay, it's like a laparoscopic procedure, if you will. But all these are for organ confined disease. The next treatment option could be radiation. Radiation could be given one or two ways: brachytherapy, which is seed implants, or you could have what we call external beam, where the radiation is shot into the pelvis. One of the other options for localized disease is cryosurgery, where you freeze the prostate and the tissue sloughs out. There's also what we call, well, active surveillance. If you have low stage, low grade disease, active surveillance may be an option for some people. Hormonal ablative therapy only recommended if the patient's health is in a state that he can't tolerate radiation or some type of surgery. Now, anytime we treat prostate cancer, potentially there's complications. Complications most common would be problems with erectile dysfunction, problems with bladder control issues, urinary stress incontinence, i.e. leaking if you cough or sneeze, things of this nature. Unique to radiation is that of what we call radiation cystitis, radiation prostatitis, or even proctitis. When you shoot radiation into the pelvis, there's going to be scatter. Some of the surrounding organs, the rectum, the bladder will be hit with radiations and can be damaged. So potentially there's always complications that can develop. But if you look at the incidence of these complications, they're very low compared to what happens if you don't treat this disease and it moves throughout the body. So, and usually there are things that can be done to correct these problems if they develop. So do not let that stand in your way. You know, the complications are manageable. First of all, the incidence is very low. Second of all, they're manageable. If you look at life expectancy with people with localized disease versus metastatic disease, there's really no comparison.
Yeah, and also, Dr. Bridges, could you touch on like one thing that I had done after my prostate was taken out was I went to see a pelvic floor therapist where they actually did exercises to strengthen the pelvic floor, to contain the urine flow, even the vacuum break to help with erections and things of that nature. So could you touch on some of those post options?
Well, I tell people after prostate surgery, the radical prostatectomy, early on, most men will have some urinary stress incontinence until the what we call the external sphincter becomes strong enough to hold the urine in the bladder. Now, the pelvic floor exercises is like an isotonic exercise where you make these muscles bulk up to become stronger and quicker. Now, if the muscle is not severely damaged during the surgical procedure, eventually you will get your control back. Some men wear pads for a week or two, but the average is going to be about 6 weeks until you get total bladder control back. The pelvic exercise really hastens the recovery from surgery. Now, unfortunately, sometimes this muscle can be damaged to the point that you can do all the pelvic floor exercise you want. If the muscle is severely damaged, you will then have to move to some other type of procedure to restore you to continence, like what we call an external, a sphincter, an incontinence sphincter that's inserted surgically, or there's a sling. Now, male slings do not work very well. Usually, if you're going to become dry incontinent if that happens, it's going to be with that incontinence sphincter that's implanted at post-op. I will not recommend anything being done till you're at least a year out from the surgery. And if the incontinence is persistent at that time, and usually it's stress incontinence, or if the sphincter is totally destroyed, you have total incontinence. In other words, you would not be able to hold anything in your bladder, which is very bad. And it doesn't happen very often. Like I said, rarely does that happen, but it can. Then of course you're going to need some type of procedure like the cuff to get you dry again.
Mm-hmm. And we touched a lot about the incontinence piece. Can we dig a little deeper into the erectile dysfunction, ways to recover, how long, it may take until you have an erection, or, tools that you can have to establish an erection? Because a lot of men, like Bernard said, they're concerned about not going to the doctor, and they're definitely concerned about their prostate and their ability to have sex, even though it's mostly reproduction. Their men tie the prostate to sex. I know I did.
Well, okay. Now, during the treatment for prostate cancers, surgery, radiation, the main reason for erectile dysfunction is damage to the nerves that run alongside the prostate to the corporal bodies or to the penis. And so if these nerves are damaged, of course, that will hurt your erections. The open prostatectomy, the robotic prostatectomy, the first thing we try to do is do a nerve sparing procedure where we tease these nerves off the prostate so that they're not sacrificed during the removal of the prostate gland. If you can do this, the patients should have abilities to have erections post-op. Now, it may take anywhere from 3 to 8 months for that to come back. Okay. Now, so if there's problems with erections after treatment, surgery, radiation, or whatever, things that you can do, vacuum systems that we mentioned earlier, penile injections can be done. Of course, the Viagra Cialis may work for some men. It's according to the degree of dysfunction that you have. Let's be honest. Most men, by the time they will develop prostate cancer, they're starting to have erectile dysfunction anyways. One thing I'll ask them, because you need to get that on the record, because they'll say, I was fine until I had that surgery. But no, I didn't. I have guys that I've been treating for erectile dysfunction 10 years. All of a sudden, I have prostate cancer to get treated. I was fine until then. I said, no, you didn't. Look, you've been on Viagra for 10 years. You got to blame something. I mean, and I understand. I mean, I'm not being mad. It happens.
It's real.
So it needs to be documented up front. And I'll tell people, if you're being honest with yourself, if you truly do not have any problems with erections, you don't have to take Viagra, you're not doing penile injection therapy, and you have a radical prostatectomy, you have about a 95% chance of being potent after surgery, which is pretty good. Remember, we're trying to cure you from cancer. And if that's successful, then the erectile dysfunction is something we deal with and try to get you through on the back end. But if you truly go in potent, then you have an excellent chance of being potent after treatment, especially for surgically. Now, radiation is a little different. The radiation tends to scar down the blood supply to the nerves, also blood supply to the corporal bodies, to the penis. So early on, you will not probably have any erection problems, but by the time you get to be a year and a half or so out, okay, then you probably will start having some problems with erections. You may need taking some extra Viagra. You may have to go to injection therapy, penile injection therapy. And we usually use the standard mixture called Trimix, which is a mixture of registine, papaverine, prostaglandin E1. Sometimes if none of these work, you may have to consider penile implant. Back in the day, when I first got to Baton Rouge, I told everybody that was my claim to fame, because I was one of the only guys doing penile implants when I first got to the city. Then they invented Viagra, put me out of business. But there's still men who would need penile implants, and it's still an option. I mean, but that would be the last thing I would offer. I would run the gamut of the oral medications, the PDE5 inhibitors, Viagra Cialis, Levitras, or vacuum systems, or penile injection therapy, and then the implantation would be the last thing I would offer my patients.
Okay, and thank you, Dr. Rich. And men who are listening and watching, and also women who love the men who are listening and watching, we talked about key sensitive issues: having sex, urinary incontinence, after effects of surgery, the different types of surgery. We're trying to cover the whole gamut so that you are informed and aware of your options. This is not, like I believe what Charlie said, it's not a death sentence. No. And not what the barbershop law may have you say. We've got facts and data here for you to operate on and to share with others, because we need to get the word out so men will get checked, men will get the treatment that they need, and men will be able to recover. And like Charlie had said earlier, it's important to communicate with your doctor. Like Dr. Bridges said something, I was fine before this. No, I've been treating you for 20 years, so it's not. So communicate, but also communicate with your significant other to let them know, hey, baby, this is what's going to happen. This is what I understand the after effects is going to be. This is how we're going to get through it together, and have that conversation up front. I mean, we should talk about sex, incontinence, just like we talk about the weather. It should be a part of our normal discussion that we need to make it mainstream. And that's one of the purposes of this call, like with Shenita in general. It takes care of these subjects that we all talk about behind the doors, then we need to just take the doors off the hinges and talk openly about it everywhere so that we can get the word out.
I just got a question for Dr. Bridges. I remember, I'm not sure if it was a urologist or someone had mentioned that sometimes if the prostate cancer is organ, but it's advanced, that the prostate is sticky, so it's more difficult to get those nerves off of the prostate during a surgical procedure. Is that true? Which can
That's
get
correct.
don't wait.
So one of the things that early detection kind of mitigates that, if you will. But if people come in with more advanced disease, in other words, there's more cancer in the prostate gland, you do biopsies, you got cancer right lobe, left lobe, apex base, things like that. Then what you want to do is you may want to have surgery, but there's a lot of cancer over here in this right side, so you may want to sacrifice that nerve bundle because the first thing you want to do is make sure you cure the patient from cancer. Sometimes we get sidetracked with everything else. You do those operations for one main thing, to cure the patient of cancer. And you deal with the problems with the erectile dysfunction on the backside. So if you need to get a wide block margin to make sure you get all the cancer out, because the bulk of the cancer will say in the right lobe, but against the capsule, you want to come scabbing along the prostate and leave cancer cells behind. Then we've wasted an operation for you. So you may want to sacrifice that nerve bundle, okay? And sometimes if it's cancer bulky on both sides, but confined to the gland, you may have to sacrifice both nerve bundles. The patient should know this up front, and the chance of you being potent after this, because there's so much cancer here, we need to do a wider block excisions. We're probably not going to be able to spare the nerve bundles, the neurovascular bundle, if you will. If you can have that discussions up front, I think it's important, okay? Sometimes you get in there, you're not sure until you actually get in there. Because we're looking at radiographs, we're looking at imaging studies that gives you a picture, but sometimes the true picture is not until you're right there doing the dissection. Then you realize, whoa, this is much more extensive than what we thought.
I have a question too that expound on. Is it true that Black men tend to have higher rates of prostate cancer than any other group of men? And at what age maybe should we start getting PSA exams?
Well, we recommend probably in African Americans starting at age 40 to get the PSA. Now, I will say this: if there's a very, very strong family history of prostate cancer, if your father and his brother and your first cousins and had prostate cancer, you may want to start at 30, 35, just to get a baseline, because you're probably going to develop the cancer at a much younger age. So you want to pick it up when there's things before things spread, of course. So that'll be a little different. Now, I think the other question is repeat it again. I'm sorry.
Do African American males tend to get prostate cancer at a higher rate than any other group of males?
There appears to be a slightly increased rate or incidence of prostate cancer in African American men. There are some studies done that says that it's more of a socioeconomic thing that happens. We're less likely to go get the annual exam, the annual PSAs, because of financial reasons or for fear doctors, for what we've heard in the past. I was in the Army. We did a study looking at the incidence of prostate cancer in soldiers, African American soldiers, white soldiers. And there was no difference because everybody had access to healthcare on an equal basis. Okay. The incidence is it a much more virulent disease in African American men? And that's one of the adages that we go through. And I'm going to say that's probably not true. We just tend to get diagnosed at a more advanced stage of disease, so our outcomes are worse. Okay. As the cancer continues to grow, the virulence of disease changes. In other words, we talk about Gleason score when you do the biopsy. They say a Gleason score 6, Gleason score 7, or 9 or 10. The higher the Gleason score, the more aggressive the prostate cancer cells are. Okay. So if you're waiting later to be diagnosed because you're not going in to be checked, then of course you're going to have a worse outcome. You're going to have more aggressive disease. I think socioeconomics have probably more to do with this than we really want to own up to.
That's great guidance. And again, eliminating the saying based upon what people have heard or read and dealing with facts and data. Question for you, Doctor. How and when should people decide on the treatment plan, whether it's radiation, whether it's removal or active surveillance? What are some determining factors?
We'll start with active surveillance. To me, if you have low stage, low grade disease, in other words, you come in, your PSA is like 4 or 5. The biopsy shows that you have like a Gleason score 6 cancer, or Gleason score 7, maybe, or a 3+4 type cancer. These are slower growing cancers. But on that specimen, you have to have something less than 10% involvement of the tissue. That means you have a small volume of cancer, you have a low grade cancer, okay? Then you consider surveillance, okay? If you have a Gleason score 8, I don't care if it's 1% involvement of the tissue, you need aggressive therapy because that's an aggressive disease. The chance of spread goes up, okay? So Gleason score 8 and above, surveillance would definitely be out under any circumstances. Now, we determine, we try to determine at least, is the cancer localized to the prostate? We do this by doing bone scans, CT scans of the abdomen and pelvis, and something that's really come online lately has been the MRI of the prostate and pelvis, okay? With the MRI, probably is the best imaging going because we can see if there's any extension of the cancer through the capsule of the prostate. Are there any lymph node involvements in the pelvis? In other words, is it truly organ confined disease? Now, we know that once the PSA gets above 10, you're starting to look maybe potentially for locally extensive disease. You get to 20, the chance of having locally extensive disease is very, very high. So the higher the PSA readings, the likelihood of spread is increasing. But we still always try to stage these people, the patients, with the modalities, bone scans, CAT scans, MRIs. And if all that shows that it's localized disease, then you want to proceed with either radical prostatectomy or radiation. Aging comes into fact, and of course, comorbid medical illnesses. If you got severe heart disease, you got a cardiomyopathy, you're not a good surgical candidate. You need to be considering external beam radiation. Even brachytherapy would be out for you because you have to undergo general anesthetic. Somebody like that, you want to say, listen, external beam radiation is probably a better option for you. So it'll depend upon the patient, his health, his personal desires as to what he wants to be treated, and you go from there. Now, a lot of people say if their life expectancy is not greater than 10 years or greater, then we shouldn't even be doing PSA. But see, my problem with that is you're starting to play God. I have a lot of guys in my practice that are 85, 90 years old. They're still driving. They're still chasing, if you will. So what you gonna tell them? I'm not doing a PSA on you anymore. He may live another 10, 15 years. He may live to be 105. So do you want him living with metastatic prostate cancer? I would think not. So I treat individuals. I treat people. Now, if you come in here, you've had 2 strokes, you just had an MI, and you're 80 years old, probably won't get a PSA on you, okay? Because you're probably going to die from your heart disease or another stroke.
It's real.
But if you come in, you're 80 years old, you're still golfing every day, you're still driving, and you're asking me for Viagra, then I'm going to say, okay, we need to stay on top of this guy and keep him healthy as we can. So, treatment becomes an individual thing, health thing. Each person is going to be different. So sometimes you have to look at the options, what personal that you want to have done, my overall health, and take the advice of your urologist. He'll say, listen, This thing has moved to the point that we can't cure you surgically because you have locally extensive disease. Then you may want to go with external beam radiation with hormonal ablation. So this would be something that you'd have to, finalize with your treating urologist. And most people will say, first of all, if you got locally extensive disease, there's no need to do a radical prostatectomy. We cannot cure you. So you subject the patient to surgery, a massive surgery, for no reason, because he still got to have radiation. He still has to have a hormonal deprivation. So it depends upon what stage of disease you are, your overall health, and what you care to have done to you. A lot of people don't want a surgery. People want radiation. A lot of people are scared of radiation. So you have to accommodate the patient in their fears.
Yeah, and I appreciate what you said, Dr. Bridges, especially how you said it's on an individual basis. As a doctor, you're doing an individual assessment on that patient, not something that they read in the medical journal or the back of a comic book or something like that. You're designing and treating it for that specific patient. And that's critical. And that's what important, having a doctor-patient discussion, open and honest, to get the best treatment possible.
Exactly.
Yeah. Charlie, did you have those type of discussions with your doctor?
I sure did.
Excellent.
And that's something else that I want to emphasize is, as men, also as women, anyone going to see a doctor, don't be passive when you go in. Have questions. Ask the doctor questions. If you don't understand something, make sure you. And this is just my opinion. If you have a doctor and you ask them questions and they don't want to answer, or they think they are beneath answer, you need to find another doctor, because it's a joint effort. So yes, definitely talk to the doctor and write out questions ahead of time so that you won't necessarily forget them while you're talking to the doctor.
Yeah, and I want to emphasize that right in my head of time, because once you're in there, your mind is going 12 different ways from Sunday, as I used to say. But writing them down gives you clarity. And even if you can send them to your doctor in advance and he has time to read it. I know, Bernard, you're great with overall health. We've been talking about prostate cancer. Like the doctor said, there's no specific diet, but general health is critical to the success. And like Dr. Bridges said, some people come in with other health-related symptoms that complicate the treatment. So I just want to emphasize, as we wrap up in the last 8 minutes or so, the importance of just overall general health, not just for prostate cancer, but we as men in general.
We know what we should be eating. We choose not to eat it. We know what tastes good and we know what's bad for our bodies, but we make choices. And those are choices we make and we have to live with them. Generally, I would say focus on an anti-inflammatory diet. Inflammation throughout the body has negative effects any way you look at it for every organ system in there. And I'm sure the doctor would be able to agree with that, because you are what you eat. That old adage, you are what you eat. So just because you're a certain age, I like this saying, you're never too old to change. And it's your call. Believe me, I don't like walking for 2 hours every morning or 5 o'clock. I got to wear a little yellow vest to make sure somebody doesn't hit me, if they're sleepy and groggy. I had to jump off the road the other day. The guy was sleepy. I guess he was groggy. I don't know. But I know it's going to have an effect. So as I live whatever years God's going to give me, I can try to stay as healthy as I can. And that's not in dispute, high fiber, anti-inflammatory diet. And I'm not saying go cold turkey, but you understand what you must do, and it's going to be your choice, and you can do it.
Thank you for that. Before we all leave, would you like to share any advice to someone who is challenged in this area of their health, or if they know someone who is? Just some guidance if the people feel challenged in this area, or some guidance that they can provide a loved one.
Yeah, Dr. Bridges, I think he'd be the best.
Well, one of the things, like I said, if there's a family history, it's important to talk to your brothers. You'd be surprised how many people want to keep their illness a secret, especially illnesses that tend to be familial, illnesses that tend to run in families. You need to let your kindred know what's going on, so they can look out and start doing things to protect and to take care of themselves. And there's nothing afraid to talk about what's going on with it. I mean, you know, why is it that does it make you less of a man to have prostate cancer? If you have it and you don't get it treated, you're going to die. So everybody's eventually going to know anyways. What is the fear? You know, and right now, I'm going to have to throw this in. We also need to encourage people to get the vaccinations. I know this has nothing to do with prostate cancer, but right now, Louisiana is, I mean, we're in trouble down here. And we only had 37% of our population vaccinated. And everybody wants to go out and go to the festivals and not go to the football games. And the Delta variant is kicking our butt down here. And it's happening across the country. You'd be surprised how many people are not willing to be vaccinated. And unfortunately, some are in the healthcare community. And I find that hard. So do me a favor, when you talk to people, try to get people to understand. Vaccines have been around for a long time. This vaccine was developed rapidly because of the new technologies that we had. The Salk vaccine, i.e. the polio vaccine, took years to develop. We didn't have the technologies back then that we have now. Whoever thought we'd be able to ride down the road in a car, talk on the telephone and looking at the person we're talking to. Things have changed, people. Get vaccinated, because that's the only way we're going to get our country back to being able to do what we want to do. And I'm sorry, I can't emphasize that enough. So I preach that more right now for practice than anything else. Have you been vaccinated? If not, why? You know, then I give them my little spiel to try to encourage them to get vaccinated.
You know, if I may, real quickly here.
Sure.
Remember when polio was, you know, in our, nobody ever said, don't get the polio vaccine. Oh, I don't know about that. When you see kids who were paralyzed, there was no hesitation. Why now all of a sudden we have a vaccine that is proven to keep you out of the hospital and reduce your mortality? Are people saying, well, I don't know, I need to think about that, or I'm gonna get it sometime, and then end up in the hospital in ICU? So I always said, if you let me do it, I put billboards. Listen, can you tell your kid eye to eye, I said don't get this, and have them get polio?
I mean, think about it. And it's so true. When I remember they came to the schools to you got your vaccination. And if you weren't in school, they went to your house. There was no getting around it. And guess what happened? Polio, diphtheria, mumps, measles, rubella, gone, people. We don't let the politics and the politicians especially make you unsafe. And because they do it because they understand if they create enough confusions, it keeps the funds coming into their pockets. Now, I'm not against politicians. We need them. But some of them have to grow up and start being reliable, responsible citizens. And what's wrong with being a good citizen? What's wrong with wearing that mask?
That's right.
When I grew up, there was a subject we taught, citizenship. You had to take the class. You had to learn to be a good citizen. That's what we have to get back to here in America. We've forgotten how to be good citizens. This world is not all just about you and your personal preferences. You live with people. It's not right for you to endanger their lives or their kids' lives. Be responsible. I mean, I don't know what else to say.
Yeah, that was enough. That said it right there, because it all ties in together. The subject was prostate health, but we're talking about overall health also. I have a friend, unfortunately, right now who's in ICU due to the virus, right? And so if you don't get the word out, it's not publicized in the mainstream media as much, but people are still going through serious things. The numbers are going up, and we want to take care of our health. So get vaccinated. I'm a proponent of also, I've been fully vaccinated. And also have those discussions about vaccinations, breast cancer, prostate cancer, these type of meetings where people can get clear direction about what's real and what's not just out there that you're hearing on the street. I want to thank all of you, men, for all of the emphasis that y'all provided for us as the general public. And I want to encourage everyone to share this knowledge for people, especially men who have not had annual exams. I know one who hadn't had one for 30 years until I finally talked him into it. So thank you, gentlemen. I appreciate your guidance. I appreciate your wisdom. And on behalf of all the people who are listening, good health to everybody. Take care. We'll talk to you next time. This is Life with Shenita.
Good.